and if you could keep an eye on that, that would be brilliant. Okie dokie, so before I get started, I just wanted to introduce myself. So my name is Julian. So I'm the co-research lead for CORC alongside my wonderful colleague, Jenna Jacob. I'm also head of evaluation at the Anna Freud Centre and a professor of evidence-based child and adolescent mental health at UCL. So stitching all of those unwieldy job titles together, I'm a researcher, and my main area of interest is empowering young people and families to manage mental health and mental health care with a focus on social inequalities. And hopefully this theme of empowerment is something we're going to be seeing as we go through the presentation today. So I'm just going to start sharing my screen. Okie dokie, there's a black bar at the top of the screen. Yeah, I'm hoping that will fade away. Apologies, I can't seem to get rid of it. Yeah, hopefully it will fade away. So yeah, I'm delighted to be talking about this project we completed earlier in the year. It was a 3-year project looking at community forensic child and adolescent mental health services, or community F-CAMHS for short. And really what this project was about how we can help the system to better support young people with multiple needs. So this was a 3-year project where we were working on the evaluation. So it was a massive team effort, and I'd like to thank all of the people who were involved. Also to thank NHS England and Improvement, who commissioned the study. But also I have to say, not only were the sites involved delivering the community F-CAMHS services, but they were a huge support in the evaluation, collecting the routine data, which all of us on the screen know is no small feat. But also, you know, we spoke to children, young people, parents and carers. So I want to say a massive thank you to all of them, because without them, we wouldn't be having anything to talk about today. So I suppose the key messages I wanted to get across was, first of all, that community F-CAMHS is a service for children and young people with multiple needs. And this is particularly those with high forensic needs in the context of mental health needs. So the input from community F-CAMHS services, we found evidence that it was associated with improvements in mental health, well-being, overall health, and quality of life. And one of the main reasons why it had this impact was that it seemed to be delivering person-centered care. And these were young people with multiple needs in a high-risk context. So being able to manage this risk without losing sight of the child, so being sure to empower the child, the family, and really make sure their voice was heard in this context of high risk seemed to be a really important mechanism, as was bringing together and supporting professionals in the network. What really surprised me was how the model not only adapted to the pandemic, but it seemed to really benefit from increased flexibility of remote working. And one of our main conclusions was that there's a real potential to scale up the model of community F-CAMHS to other vulnerable groups. And this might be a way forward in achieving this step change to have integrated care across a dynamic and multifaceted, complex system to support those who need support the most. So I'll be going into some more detail about what community F-CAMHS are, what we did in the evaluation and what we found, but also I'm really interested to hear your views, whether our findings fit with your experiences, but also on this topic of, you know, how do we support the system to work most efficiently and effectively to best help young people with multiple needs. It was quite a complex study. So if you're interested in more details, please do check out the protocol that we have published on our evaluation. So community F-CAMHS are 13 new services across the country. They were commissioned 3 or 4 years ago. There were previous versions of community F-CAMHS before this. However, these new services were all with a harmonized service specification. So although there may have been previous iterations before these services, the aim was that these new services would really bring everything together in alignment so that young people across the country were being supported in a similar way and were having kind of parity in provision through these community F-CAMHS services. The services were quite unique, particularly when thinking about traditional CAMHS models, because the service users of community F-CAMHS were indeed children, young people and families, but were also professionals in the system. So the services provide consultation. So this could be to anyone working with children, young people and families. When a professional is concerned, when they're worried about risk, they're worried about how to best support a family, and they're looking for advice. So this could be educators, social workers, mental health professionals. Anyone could just ring up, send an email and get some consultation and advice. The next level of input is case management. So for young people who are being supported by a number of different agencies, staff in community F-CAMHS really tries to bring together these different agencies, be a bit of a bridge, not only between these agencies, but between the agencies and the family they're supporting. And yeah, this is to really help provide joint up care, but also not lose the voice of the child. When thinking about risk and trying to manage risk, it can be quite easy to want to obviously follow the right safeguarding and right processes, which of course is clearly important, but at the same time, not forgetting that this is a young person that we're talking about at the heart of this is really important and something that was a real priority to these F-CAMHS services. For some, providing an assessment of specialist needs or linking into services who could provide those specialist assessments was really important. So it won't be a surprise to anyone here that things like neurodiverse needs assessments are a real challenge to provide to young people and families. And then for a smaller number of families, community F-CAMHS provide direct therapeutic work to children and families directly. So in the evaluation, in a very big nutshell, we conducted a mixed method realist evaluation. So this means that we looked at different quantitative and qualitative data. And we were looking at these data to try and test out what we thought at the beginning would be the impact of the community F-CAMHS services, but also we set out kind of why we thought it might have these impacts, what we thought might be the vehicles to achieving this impact. So we set all of this out in different forms, different questions, logic models, and then we collected these different types of data to try and address these questions. Our primary outcome was the HNOSCA, which is a kind of needs assessment that looks at difficulties in a range of different domains. It captures general mental health and social functioning. And the reason we chose this as our primary outcome was because, and this was measured for the families who were having more direct contact with the community F-CAMHS services. Obviously, young people being supported are having, diverse needs, but also the service is supporting families in quite different and flexible ways. So although our kind of key our key values is to really hear the voice of children, young people and families in the data we collect, we thought given the nature of how this service was operating, and given that, the services would be working with families at a time when families were really struggling, we opted for a clinician reported measure as our main outcome. So we looked at different types of data, routine data collected from the 13 sites. We collected surveys from staff. We conducted interviews and focus groups with about 70 staff working in the community F-CAMHS services. We also spoke to what we've called referrers, but these are any professionals who were in contact with community F-CAMHS. So it might be professionals who had sought consultation and advice from the community F-CAMHS services, but it might also have been those professionals who were referring young people and families into those services. And then finally, we spoke to children, young people, and parents and carers. I see there's discussions going on in the chat. I hope everyone's finding their ways into the sessions that they wanted to. I hope that's all being resolved. So I'll plow on with this part of the session. So I'm going to dive straight in to the findings. And first of all, I'll provide a bit of a snapshot of the young people who were being supported directly and indirectly through community F-CAMHS, as we saw from the routine data. So we saw that there were quite a large number of males compared to females being supported by the community F-CAMHS services. And although the age range was about 14, it was really interesting that although the average age was about 14, it was really interesting how wide the age range was. And I think the bottom age of the age range, going from about 5, really surprised me. Because this was a service to support young people with multiple needs, but particularly with a focus on forensic needs. So to be seeing the high numbers of young people who were particularly young, who were receiving this service, was really interesting. We've had lots of conversations with the services about the ethnicity data. So we can see that about 76% of young people were from white British groups. And this raised lots of questions to us. And it's been really interesting how some services have been doing comparisons with their own ethnic breakdown to that of their local demographic population. And indeed, some services found that their ethnic breakdown was quite in line with their kind of wider population breakdown. But I think this raises a really important question that future research, and indeed it's something we're interested in exploring, is we know at the kind of more crisis end of the spectrum, young people from Black and minoritized ethnic groups are overrepresented. So they're overrepresented in the youth justice system, but also in terms of accessing or rather receiving support, they're overrepresented in receiving mental health through things like education, social care, and youth justice. So given that Community F-CAMHS aims to support young people to avoid them reaching these crisis points where we know young people from Black and minoritized ethnic groups are overrepresented, I think this raises a really interesting question about how we can make sure young people from such groups are being supported and receiving the service so that we can avoid that overrepresentation at the latter stages. Diving into what we saw from the outcome measures. So here in the left-hand graph, we have the average HNOSCA total scores for discharged cases. So these were cases who were having more direct work with the Community F-CAMHS. And obviously there are limitations around these data. We're only looking at those who had complete data at time 1 and time 2. But one thing we were trying to do in the evaluation was not just look at overall differences over time, but to also look at whether there were any differences between those sites who were early implementers and those sites who were late implementers. So an early implementer was a site for example, who had a similar service up and running before the Community F-CAMHS, as I was mentioning at the start. And a late implementer was, for example, someone who didn't have a similar service up and running. So here we can see that there were significant differences or improvements in total HNOSCA scores from time 1 to time 2. But as we can see, the difference was bigger for the early implementer sites. So those sites who had previous similar services showed more of a difference in HNOSCA scores. So this was in line with our expectations. We saw improvements for HNOSCA for young people across sites from time 1 to time 2, but a bigger improvement in the early implementers. And then if we go down to the second graph on the right-hand side, we can see this is a similar pattern in the measure we looked at. Again, clinician reported about overall health for young people and families. So we can see higher levels of improvement between referral and discharge. This time, the scores are flipped. So a greater score indicates greater overall health. So again, it was a significant improvement from referral to discharge, and the difference was bigger for early implementing sites. In terms of the qualitative data, we looked at a number of things, but I picked out the areas that I was most interested in. So the first theme was around person-centered care. Here we heard that young people and parents and carers felt understood and listened to through the work with Community F-CAMHS staff. And they described this as being a really empowering experience and not necessarily something they had experienced in services they had accessed previously. But this feeling understood and listened to really set the foundation for them to have greater involvement in their care. And having greater involvement in their care, having this form of social inclusion actually provided confidence for them to be more socially included in their lives more generally. So it was really interesting to me that this kind of microcosm experience of greater inclusion in their care was replicated in being able to have greater social inclusion more generally. Interestingly, we heard quite a similar thing from referrers. And I have to say the similarity in what we heard from the referrers and the young people and parents and carers really surprised me. So referrers also felt empowered from the community F-CAMHS staff. And they described the work as helping to really contain their anxiety when working with young people about whom they were concerned. And they might not necessarily have had the skills or training in their day-to-day roles to support this. So they described, again, having greater involvement in the care of young people through work with community F-CAMHS staff, that it enabled them to, they had greater involvement in the care with service users, but these were really important skill development opportunities that helped them in their work more generally. So some of the illustrative quotes we heard evidencing this from young people were that they don't look at you for just what people label you, for what people think of you. They get to know you and treat you how you want to be treated, and how and not how people say that you are. So here we can see a young person saying that the community F-CAMHS staff treated them not just based on a label, a diagnostic criteria, but for who the young person was. A parent and carer described how what you find is everyone has their own opinion when talking about professionals in the network supporting them. So you've then got everyone's opinion, and that's really difficult. And you need someone who is professional and trained and qualified to step in. But he was there for our son as much as anybody. It was very much his voice that was heard, which was good. So here we can see the parent and carer saying that the community F-CAMHS staff was able to not only join up the other professionals, but to help in a way provide a kind of clarifying voice when different professionals might be giving different opinions. And then finally, we can see a referrer saying how they were actually part of the equation and the decisions, and that they were being able to kind of get stuck in and help and sort things out. And that this was much more of a problem-solving approach. So they felt that they and the children and families were kind of not done to, but kind of done with. The next theme I found interesting was about multi-agency risk management. So the different groups we spoke to described how community F-CAMHS really helped to manage risk across the network without losing sight of the individual at the heart of this. And this was really facilitated by community F-CAMHS kind of getting stuck in, being part of the network, but also by having this role that was slightly outside of the network. So to illustrate this, we saw parents and carers saying that the community F-CAMHS helps to bring everyone together. They came to school meetings and they were really helping to join everyone together, not just in terms of the sort of mental health services, but also the school services, and how the F-CAMHS really helped to join the dots and have a bit of a bigger picture, which really was reassuring and helped the parents and carers kind of have something to anchor to. We heard from referrers that community F-CAMHS provided consultation about local services and how those could be best used to support young people, to really try and make sure young people weren't falling through the gaps in what was or wasn't being provided locally. And then we can see an example of a referrer saying how a school had real concerns, and that actually having a member of F-CAMHS to come in and provide a different perspective helped the school to manage the risk in a different way, and supported the team in their decisions and recommendations. So lastly, I wanted to kind of touch on some examples of the impact that we heard from young people, families, referrers and staff working in the community F-CAMHS services. So there were a range of impacts going from supporting young people to avoid a custodial placement, referrers saying how it would have taken much longer to have social care input, and that the length, by being able to speed up the receiving social care input, this actually helped to reduce the risks because they were getting involved without having to go through this sort of limbo waiting period. And by the community FCAMHS stepping in and providing this safeguarding support and engaging with other services in a timely way actually helped a young person to avoid being criminalised. So this time we have some quotes from parents, carers and young people. Parents and carers on the left-hand side described how the support helped to mend relationships in the family and prevent family breakdown. It helped the families to openly talk about and acknowledge struggles and mental health issues amongst the family. Moving on, we can see an example of a parent and carer saying how it avoided kind of a crisis point. And that help and stepping in now meant the family no longer felt they were in such a crisis point. And again, we have another example of someone saying how it avoided a placement in the youth justice system. Moving to the right-hand side of the screen, we can see some further examples. And I really like this first one because we often can get fixated on these kind of outcomes, avoiding youth justice services, but actually this one is a really important example of an impact to the day-to-day lives of young people, because by helping this young person to feel less socially awkward and anxious in their own words, it helped them to feel comfortable and open them up to the world and people around them. Helping parents and carers to have coping skills and to help the parents and carers to cope with the challenges that they're experiencing was another example of impact. Here we can see a young person saying how the impact helped them to move away from previous criminal activities. And then finally, we can see a parent and carer saying how the input helped them to get a kind of specialist school placement, which has helped the young person to really thrive. I wanted to mention some limitations. So obviously, there was a huge change to the context and working environment with the COVID pandemic. And this was clearly not something we'd anticipated when we started the work in 2018. As you'll have seen from the findings and the quotes, we heard lots of positive comments from people that we spoke to. This obviously might reflect a self-selection and social desirability bias, in that it's possible those people with more positive views were more likely to participate in complete materials. I have to say, we really made it clear and explicit that we wanted a range of views. And I think what reassured me was that we heard similar things from different groups that we were speaking to. And of course, we did hear negative feedback. But again, this was around parents and carers saying that they wanted more input from the community FCAMHS services, and that staff in the services were saying that their concerns with that were that they were providing more day-to-day CAMHS services rather than the kind of specialist community FCAMHS input. So I feel we did kind of touch on some of these sort of less positive responses, but nonetheless, I think it's important to be mindful of this. We used routine data, and we'll all know that there will be differences in how sites collected, coded, and use the routine data. And obviously there will be young people seen who weren't in the data that we aren't representing. The numbers of young people and parents and carers we spoke to was relatively small. We and the sites we were working with tried really hard to make taking part in the project inclusive. Given the nature of the service and its less direct work with young people and families, we did anticipate this from the start, but nonetheless, we really, want to acknowledge that the voice of children, young people, and parents and carers directly was not as strong as it possibly could have been. So to recap, the main messages: community F-CAMHS are services for children and young people with multiple needs, particularly forensic needs in the context of mental health difficulties. Input was associated with improvements in mental health, well-being, and overall health and quality of life. And one of the main drivers of this seemed to be the person-centered nature of the work, where they were empowering children, young people, and the professionals in the system, and they were able to manage risk and help the system to manage risk while still empowering young people and professionals. I didn't go into the findings about the adaptation to the pandemic, but just to briefly say, one of the reasons this really thrived was because of the remote working. So community F-CAMHS are small teams that cover a wide geographical area. So obviously through remote working, it actually meant they were better able to support a larger number of people from diverse geographical areas. And finally, this model seemed to be a really interesting model that might help to scale up to other groups about how to support the system around them. I'm going to stop talking now. So please, I welcome any views, how the findings fit or don't fit with your experiences, questions, comments, reflections, but also this wider question about how we can support the system, supporting young people with multiple needs.